Good afternoon, friends. Welcome to the 19th webinar program by Indian Dental Association, Mumbai West Suburban Branch. I, Secretary Dr. Vinder Sanghvi, along with my President Dr. Vijay Agarwal, my Treasurer Dr. Pratibha Shetty, my CD Convener Dr. Jashan Arora, and the entire EC members, welcome you all to the series of webinar sessions which are conducted free of cost for the betterment of our dental fraternity and all our dentists. Today we have a dynamic speaker, Dr. Amit Gupta, who is going to speak on bone graft substitutes, when and what to use, where and what to use. We have a series of lectures post Dr. Amit Gupta's lectures. The speakers which we have are Dr. Parag Kelkar, who is going to speak on routine dental procedures which can ruin your practice. We have Dr. Yusuf Chunawala, who is going to speak on painless dentistry. Then we have Dr. Kapil Golwankar, who is going to speak on post and course. Then once again, we have Dr. Yusuf Chunawala, who is going to speak on bad breath. Then we have Dr. Satish Iyer, who is going to speak on pulp therapy for primary teeth. We have Dr. Dhanamraj Patil, who is going to speak for pediatric rotary endodontics. And we have Akshay Rathi, Dr. Akshay Rathi, who is going to speak on clear aligners. The dates are going to be 18 to 23rd. Details will be sent to you on all the respective webinars groups. Request to you all who have been into any of the webinars group from 1 to 5, please don't be in any other groups of webinars. Please exit yourself either of these groups because the same messages are going to be posted on these groups so that we can accommodate others also. There is a YouTube channel of Indian Dental Association Mumbai West Suburban Branch. All the previous webinars, today's webinar, and the forthcoming webinars are going to be telecasted on this YouTube channel of Mumbai West Suburban Branch, IDA MWSB. Request everybody to please go online and view this webinar live and the previous webinars. Do like and share and subscribe to this channel, which will be an encouragement for us to host more and more programs, educational programs, social awareness programs on this YouTube channel. Regarding the Zoom webinar, request everybody to please mute all your videos, all your audios, stop all your videos so that there is a smooth presentation of the speaker. There is no buffering and we can hear him, listen to him and see him clearly. Whatever questions are going to be required, they can be posted in the chat box, which is down below. The questions will be taken up once the lecture is over by Dr. Amit Agarwal. They will be answered them, and he will also be available till 9 o'clock today on all the webinar groups. You can after the lecture also you can definitely ask the questions on this webinar groups, and request Dr. Amit Gupta to please share your details so that dentists can be benefited later on also if there is any problems to them regarding when the post-COVID their treatment starts, the practice starts. I request Dr. Jashan Arora to please welcome and introduce our speaker, Dr. Amit Gupta. Dr. Jashan, over to you.
Dr. Viraj, thank you. We have with us today Dr. Amit Gupta, who is an oral surgeon and an implantologist. He has completed his MDS with gold medal from D.Y. Patil Dental College. He has a diploma in healthcare management and medical legal from Symbiosis Pune. He is a diplomat ISOI, fellow ICOI. He has advanced implantology from Steinbach University, Germany and Tufts University, USA. He has a vast experience of 23 years in implantology and key opinion leader for Aiden, Dentium, BNB private implant companies. He is the joint secretary of ISOI currently, and he is a national speaker on topics related to oral surgery and implantology. Sir Amit Gupta, the screen is all yours. Thank you.
Friends, Dr. Amit, just a minute, friends. Dr. Amit Gupta is one of those person who has brought Indian Dental Association Mumbai West Suburban Branch to a stage where it is right now, and it has become really difficult for us to maintain that level which Dr. Amit Gupta has created for the branch. Thanks, Dr. Amit Gupta. Over to you.
Thank you, Dr. Viraj. It's not only me, but it's always a joint effort of all the senior dentist practitioners in suburbs who have been there, like Dr. Dharmaji, Dr. Jitendra Shah, Dr. Vijay Baldava, and many more. Dr. Durgesh is there, Dr. Vipul is there. So it is always a joint effort. It's never alone me. And Jashan, thank you for the wonderful introduction. And I hope I can give justice to this. I'm sharing my screen right now. And here we have, okay. So today we are going to, uh, just a minute. Okay. Today the topic is bone graft substitutes, where to use what. We've always seen that lot of company representatives come to us saying that, okay, this is one of the best bone graft material available today, and you have such and such doctor is using it, or such and such implantologists, some senior implantologists are using it. So we generally follow to what they say, and even in the conferences, even the lectures, where we see in the conference, they say that I've used a xenograft or a autograft or a allogenic graft. But do you know exactly why did they use that, or how did they use that, or what was the reason for them to use that? So let's start with this topic, where to use what. So to know where to use what, we need to know why exactly we are using it. What is the benefits? What is the chemical composition, or not chemical composition? At least why they are being used. What is the resorption time? Where does it help in osteogenicity and all that? Okay. I just came across this wonderful slide which uh, says that dentist, after attending hundreds of webinars, finding that his helmet doesn't fit on his head anymore. Doctors are calling this medical condition, most commonly found in dentists, as acute cephalomegalis webinaris. I hope uh, we have not reached to this level, because there's a lot to learn and lot many topics to be covered in. But in case if you feel so, it's best to implant dentistry, which is considered to be the oldest treatment module along with oral surgery, maybe almost around 4,000 years old. And you've seen that after extraction or after removal of tooth, there is almost 25% in decrease or resorption in the width of the bone in the first year. So just imagine you have a good 15 bone, which reduces to almost 12 or 13 in the very first year, and slowly in the next 2 to 3 years it reduces to 40 to 60. The height, which is a very important factor, which reduces to almost 4. Depending upon what type of processes you're going to place over there. If you're going to place over there something called such as a removal, where the pressure is applied on the tissues, the resorption rate is much faster. So the summary of my lecture would be basically an initial start with the definitions, the description, what would be the requisites of an craft, where to procure from, or where do we get it from, or where to use what. Why? Because this is basically I'm conducting this lecture not for an advanced level, but at the basic level, because many of the dentists who have come to me and who are known to me, they asked me, sir, which bone graft do you use? or they ask for this case, how do you choose your bone graft? So to summarize all those things, a
Sir,
small way to go ahead.
Amit sir, sorry to disturb. We are having some issues in your voice. Your audio is not being heard clearly, sir.
One second. I'm changing my Wi-Fi settings. I'll just check. Is this better now?
Yes, sir. अभी तो बराबर आ रहा है.
Okay. In case anything, just let me know.
Yes, sir.
Right. So this is a very basic topic of lecture about bone grafts and the choice and how to go about with it. Let's go ahead. Now, if you have to place an implant, remember one thing: you need enough amount of bone all over, whether it is natural or
Sir, no audio, sir.
Amit, Dr. Amit, still there is a problem. Sorry to
Yes,
disturb.
sir.
Rather than try using earphones now if it is possible for you.
one second.
Yeah. Welcome, Dr. Komal Majumdar. She has just entered. Welcome, Doc.
Hi,
Hi, Komal.
hi, Amit. All the best for this. Looking forward.
Thank you.
Ma'am, good to have you on this forum, ma'am. Thanks a lot
My pleasure.
for
Thank
coming.
you.
Dr. Viraj, am I audible now?
Right now you're audible, but in between it was cracking. See, this time, next time if it occurs, just request you to use your earphones if it is possible for you.
Yeah, sure, I'll do that.
Yeah, thank you.
Okay, so as I was continuing, for any implant dentistry or any implant placement, you need to have abundant amount of bone around your implant to be successful. Whether it is the natural type of bone or whether it is an augmented type of bone, whatever it is, we require bone. And in case if you don't have, which is due to resorption, which can be either physiologic or pathologic. Physiologic would be simple age-related resorption, which takes place after the extraction of your tooth, and this leads to non-functionability of the part of the alveolar bone, which causes reduction in the height as well as the width. In case you have something which is pathologic like trauma, infection, lesion, or any pathology, endodontic pathology, or it is developmentally absent. In such cases, also we require to have enough bone structure, which may require augmentation to have a good implant placement in that area. The only way to regenerate such type of bone is to have a wonderful knowledge about it. There are multiple books available in the on YouTube, or you can see various clippings, or you can listen to wonderful speakers like Komal, Dr. Lanka Mahesh, Dr. Paresh Kale, and all those international speakers also. But without having a good or thorough knowledge, it is not good to venture into the part of augmentation. You have to have a guided regeneration in that area. It is basically directing the growth of bone in required spaces and restricting non-osteogenic growth in these areas. Now, if you have something which does not allow bone growth, you have to create a barrier such that you do not want any fibrous or non-osteogenic growth, which can hamper the stability or success of your implant. Goldman and Cohen had basically classified the defects post extraction or maybe during before the extraction. These were depending upon the wall or the natural bone available around its structure. If it's considered a tooth in the place, the most important thing which we require to know is uh, how many walls are present around that tooth or around that socket. You have a one wall, two wall, three wall, four wall combined defect or a five wall defect. A five wall defect is basically a defect where you have an extraction socket, you have both the mesial and the distal walls, as well as the buccal and the palatal or the lingual wall, and the apical wall, which is at the surface of the root. So what we need to know in this case is the basic knowledge about all these things. What is a graft, what is grafting or augmentation, what are the types of bone grafts, a good historical review, objectives, rationale of bone grafts, and the biological concept of using such bone grafts, where to use what. A graft is a viable tissue that, after removal from a donor site, is implanted within a recipient tissue and is restored, repaired, and regenerated. That means when you place a tissue which is from the recipient side, it should regenerate into a similar type of bone, if not exactly the same type of bone. So these bone grafts functions as structural scaffolds, matrices, or it can cause bring in proliferation of osteoblasts. Now, considering this, we always have this question: which is the best bone graft material? Which the question which always has been asked to me, as well as to many of the speakers I know, and they are always saying that okay, I consider this as the bone graft. But what can be the reasons? What is the ideal characteristic a bone graft would require? We have I've listed a few characteristics which need to be taken into consideration before we choose a type of a bone graft. It should be non-toxic. Non-toxic in the sense when you place it, it should not cause any allergic reaction or any inflammatory reaction. It should be something which is an inert material. It should be non-antigenic. There shouldn't be any antigen antibody reactions, which can lead to further complication rather than getting the benefit of a bone graft. It should be resistant to infection. Definitely nowadays you have such graft materials which are very much sterile or sterilized properly with all the protocols and principles keeping into mind, and the chances of infection are less, but definitely this is one of the big criteria. So in such cases, you will always say that how do you differentiate between a good graft which will not cause infection or a bad graft? My personal opinion would be something which has a very good review or very good backup, which has a lot of R&Ds, will be a better choice of company from where you buy the grafts. Such grafts should always facilitate vascularization because this is the key to any type of maturation or any type of augmentation. Until unless you don't have blood vessels which are growing within the graft material or any type of mesenchymal cells proliferation, you will not have a good bone conversion in that case. Strong and resilient, yes, it shouldn't be very powdery or something like that, that the moment you place it, it gets sucked away or it is not able to. So in that case, it should be easily adaptable, not very thin or not very big enough for that. It should require minimum surgical interventions, which will come into autographs, where you can manage to attain such grafts from minimum sites rather than going to extra or large sites. It should simulate new attachment and be able to trigger osteogenesis cases where you have autographs which definitely help into this type of osteogenesis. But yes, you have a few of the allograft also, which can cause help into osteoconduction or osteoinductions. We'll go further into the lecture and then find out what is all this I'm talking about. And finally, this graph should replace the native bone having the same or similar quality bone, such that you do not have something which is a substandard quality of bone, because a substandard quality of bone will not uh, give you good stability or success in your implant dentistry. To know your graft has to be perfect, or it has to be a good success rate, you need to know the principles of your bone grafting. Now, the host bone regeneration capacity. Uh, uh, Wherever you have a bone which is very healthy and futile for regeneration, it's always good. Any cases where you have osteoporotic or a bone which is undergone a radionecrosis will not be a good host area to regenerate such bone. Surgical asepsis, nowadays everyone is bothered about asepsis, whether it is the normal bacterial infection or the latest COVID-19 viral infection. So I don't know how to go about in future, but right now we can just think of giving the best surgical asepsis in this bone graft materials. Host site preparations, we do not require much of preparation until unless it's more of a cortical side of bone, where you may enhance or encourage bleeding from these cortical bone plates by pinhole or puncturing the cortical bone with the help of a small burr. So basically, it is to improve or increase the blood circulation in that area or accumulation of blood in that area. Optimization of growth factors, you can add for a few growth factors. Definitely, they are an adjunct to what you growth factors which are available into your autogenous bone graft. Immobilization would be a key factor into any bone graft which would mature into a normal bone, because a good bone will never develop in a graft which is does not have immobilization, as it may lead to fibrous union or granulation tissue formation. And soft tissue coverage, in if the graft is exposed to the oral cavity, this will definitely get infected and rejected. So we need to follow these principles if you have to have a good bone graft success in your cases. Let's talk about the biological requirements of these bone grafts. The biological requirements, the words, the terminology which we are going to use are the osseointegration, osteogenesis, osteoinduction, and osteoconduction. Now, what is osteointegration? It is basically the ability to chemically and biologically bond to the surface of bone without any intervening layer. That means if you're placing an implant in your bone structure, there should be growth of bone inside the microporosities at the surface of your implant. There shouldn't be any intervening tissue which would hamper or which would be sandwiched between the implant and the bone. In such cases, you may always have an implant failure. So, also integration is the basically a direct bone to implant contact. Osteogenesis is basically the formation of new bone by osteoblastic cells present within the graft material. So it is the graft which helps forming new bone, rather than it by creating osteoblastic activity which are present itself in the graft material, and such can be available only with autografts. Osteoconduction is the ability to support the growth of bone over its surface. It is basically a scaffold which is open. Hello, can you hear?
Yeah, Amit, we can hear. Just
Okay.
a minute, friends. Please mute your audios. There are some participants whose audio is really heard in the background. Please mute your audios and stop your videos. Yeah, Dr. Amit, you can start.
Okay. So basically, osteoconduction is does not help in the osteoblastic activity as per se, but it forms a scaffold around in that area. Uh, I think there is some audio whose audio is on, so kindly mute your audio. Thank you. So it helps as a scaffold. So in this scaffold, there is growth of capillary network, which helps in the blood circulation in that area, helping the osteoblastic cells to get transported and form into an osteoid, and then later forming into a bone. Osteoinduction is basically these bone grafts where the ability to they have the ability to induce differentiation of pluripotential stem cells or mesenchymal cells from surrounding tissues to an osteoblastic phenotype. By this, I mean to say that when you have something which is inside the graft, which will uh, encourage the surrounding mesenchymal cells to transform into an osteoblastic cell, which will help into the bone growth. So this is called osteoinduction. If we consider the classification of the types of bone grafts, it all depends upon one, the origin, which can be autogenous, allogenous, or synthetic. Two, it can be in origin. I missed on xenograft also, which is from the bovine source. In blood supply, we have vascularized or non-vascularized. And in the quality of the bone, we have the cortical or the cancellous or a combination of cortico-cancellous bone. What can be the source of these grafts? If we consider autograft as the first, it is basically a graft which is taken from the same individual's body. That means a patient from the same patient you are taking from other site and then transporting it to the required augmented site. We can have it from the symphysis, the ramus, the maxillary tuberosity, or any extraoral area like the iliac crest. And if you have a mandibular or a maxillary tori, you are more beneficial into that. So if we consider the intraoral sites, we have the maxillary tuberosity, we have the ramus of the mandible, we have coronary process, zygomatic process. This is just a brief how much volume we can get from all these areas, and according to the area, we also know which type of bone you're going to get, whether it is more of cancellous or more of a cortical bone. So depending upon the requirement, you can choose the site of your graft harvesting. If you look for the extraoral sites, we have the tibia, the anterior and the posterior iliac crest, or the calvarium. When we are talking about these autographs, we always know that this is supposed to be the gold standard, the best type of graft available. So what would be the advantages? It includes cells which are going to participate into osteogenesis. As I mentioned, it is going to be the best type of graft. There is the tissue reaction uh, is induced without inducing immunological reactions. Why? Because it is from the same patient. There would be minimum inflammatory reaction, and revascularization of the graft is very high because the structure is similar to the bone which is present where the host site we are going to augment the graft. There would be potential release of growth and differentiation factors which are secreted within the graft. So basically, it is one of the best replacement modality where you can get all the basic factors for any type of growth in that area. But though, because we have to take out part of the bone from some other side, surgical morbidity, the patient might refuse to operate on any other side, saying that no, you can try something else. And when you are going to when you require a lot of quantity, or then in that case you might have some limitations about the quantity of the graft. So in such cases, we look for some other venues for grafting. What would be that? Autogenous dental graft. Autogenous dental graft is basically a graft which is from the extracted teeth. Now, these extracted teeth has to be from the same patient itself also to avoid any type of antigenic deformations in that case. Autogenous tooth particulate which human extracted teeth may be considered a potential material for bone regeneration due to its chemical composition and the high quality of material obtained from each tooth. So basically, what we can have something now. Suppose you are having a tooth which has been extracted. You can use the same tooth and into your dentinal grinder use the same uh, as a graft material. Definitely it has a process or for the formulation of that which can be taken into consideration. Next is your allograft. Now, allograft is basically from the same species or the same individual, from same, but from a different individual, not from the same individual, from a different individual, but the same species. Now, this can be two types of grafts. Basically, it is freeze-dried bone allograft or demineralized freeze-dried bone allograft. This is the next choice of graft when you cannot go for bone graft, which is where the patient or the autograft, where the patient refuses for another surgical site, or in case where you need the quantity is more, then you can think of going for allograft. Now, if you talk about FDBA versus DFBA, it is basically uh, freeze-dried bone allograft versus demineralized freeze-dried bone allograft. FDBA basically it is a more of a osteoconductive scaffold. It will not help into any type of osteogenesis or help of any type of self uh, growing factor which is not present over there. It will cause resorption when it is implanted into mesenchymal tissues. It has a very slow or delayed resorption, and hence it can be used for better space maintenance. FDBA is more radio opaque as compared to demineralized. Now, basically, what is demineralized? When the protein content of this FDBA is exposed, it helps into an osteoinductive property, and that's the reason it is a little better than plain FDBA. Why? Because it does not only help into osteoconductive, but it is also a source of osteoinductive factors. How does it help? It elicits mesenchymal cell migration, attachment, and osteogenesis when it is implanted in well-vascularized bone. So basically, along with the conductive, it has a bit of osteoinductive factors. So we have something which is similar, if not exactly, to autogenous graft. But the drawback is it has a very rapid resorption, and because of which you cannot have it where we require long-term scaffold properties, and it is not very well illustrated into the radiograph.
Dr. Amit, sorry to disturb you once again. The audio problem has started again.
One second, just give me a break.
Yeah, please. Sorry, friends, for this technical snag. In between, this entire webinar is available live on YouTube channel IDA MWSB. The previous webinars and the forthcoming webinars by different speakers are going to be also live on YouTube channel. Please like, subscribe, and share the YouTube channel. Yeah, here is Dr. Amit Gupta once again.
Yeah, can you hear me now?
Yeah, much better.
Perfect.
Okay, so we just now we have discussed the difference between FDA, BA and DFDBA. So we can choose any one of them depending upon what is the requirement. Let's talk about the disadvantages what we have with this allograft. It does not have osteogenicity as good as autograft. Yes, if you have a demineralized type of DFBA type of graft, it does have some osteo-induction. It's not exactly like your graft. Absorption time depends upon the type and size of the graft available. There is a risk of autoimmune reaction. Why? Because it is taken from the cadaver of the same individual. But though, because of the protocols and the certifications, now the chances of autoimmune reaction is very, very minimum. Maybe in the literature, it is not seen regular for the last 20 years. Advantage is it is easily available and in ample quantity. The more you want, you can order for it. Most important thing is another side, more morbidity is avoided. It's not morality, sorry, it's morbidity. And GBR can be planned as per the maturation period, depending upon whether you want a fast maturation or you want a slow maturation. You can decide it whether you have to go for FDBA or EFDBA. Next type of graft is your xenograft, which is a surgical graft of tissue from one species to an unlike species, which is not now if you are using it in a human being, it is not from the human being, but from other sources. And right now we have the following sources available, which is bovine. Bovine is basically cow, porcine, which is pig, horse bone, or natural corals. The only drawback with xenografts, before I go ahead with the further explanation, is in bovine graft, it can cause something. The cows are having a disease called bovine spongiform encephalopathy, and which is BSE, which can cause Threadfield-Jacob disease in human beings. So this is generally present only in old age, but you have a variant of that which can be present in any age, and it is a fatal neurodegenerative disorder. So this is when you have a bovine graft. If you have a porcine graft, you have porcine endogenous retrovirus, which causes immunosuppression and mutagenesis. So if you have an immunosuppression, you have symptoms or a disease which is similar to HIV/AIDS, or you can have mutagenesis which can cause cancer. Another virus, which is the Ebola virus, which can also be transmitted through these xenografts. But because these grafts are highly sterilized, and chances of transformation is very low, still it cannot be absolutely neglected to such type of infections. So how do we basically avoid such type of infection? Is creating an organic bovine derived bone xenograft, which is a xenograft which is consisting of deproteinized sterilized bovine bone with 75 to 80% porosity. Apart from this, the most important, though patients do not ask, but many times patients do ask from what is the source of this graft. So religious sentiments are always considered in such type. So if you have a patient which is considering a religious bovine or a religious porcine, you cannot place such grafts into that. Otherwise, it is one of the good grafts. I have cited you this article, which is from Dr. Lanka Mahesh, who has mentioned about this type of infection present. And we have the final type of graft, which is synthetic or alloplast. This is basically an artificial bone which can be created by naturally occurring minerals such as hydroxyapatite, tricalcium phosphate, bioglass, calcium phosphosilicate. These are all biologically active to different degrees. That's the reason they are called bioactive, depending on solubility in physiological environment. So when you don't have anything available, these are one of the best part of replacements which is available. Very commonly used Nova bone into your immediate socket preservations, or you lately which has been used as your indirect sinus sleeves, or to cover up the jumping distance in cases of socket shield treatment. Again, we have a few advantages and disadvantages here also. The more of advantages, like we do not have any antigen antibody reaction. They are comparatively more economical as compared to allografts which are present, and or the xenografts. It is easily available, and more important, it is available in all forms, like particulate into powders or gels, or into a gun putty type of a thing. Disadvantages, only thing is it graft transformation, where you do not get good results out of, or good quality bone after placing such type of graft. So here we understand basically the source from where we take for replacements. If it is a self bone, an autograft, a same species, an allograft, a different species, a xenograft. But if it is artificially developed in the lab, it is a synthetic. Since you know what is the source of this graft, and depending upon that, you know what is the benefits and all that. Now the second question comes, whether we should choose a smaller graft or a larger graft particle, because these grafts are always present in different various sizes. So we need to know why you require a smaller or why you require a larger graft particle. So when you take a smaller particle, it is very quick to revascularize, because the porosities or the interparticle distance is pretty high. So that's the reason the growth of capillary intervention is better in such cases. It has a more of osteoclastic activity, because of which the transformation of bone or maturation of the graft particle into a natural bone is much higher. They resorb faster because of this osteoclastic activity. But the only thing is they have minimum space making. Now, if you require a graft to be placed in a huge defect, you require more of graft particles. So they are highly packed. So in that case, you require more volume of it. And if you need to have a supportive part, it will not be supportive also. So then, to have supportive as well as increased height, you need to have a large particle size graft. And for more of a scaffolding effect, the particle size has to be big. And if you don't have a particle size which are big, in that case, even if you have a barrier membrane on top, it will cause deformation or due to the external pressure of the tongue or the cheek. So basically, it is always good to have a combination of different particle size, so you can have allograft of two different sizes and mix them together and then use it as a combination graft. If we talk about the maturation or the transformation of these grafts, basically we can differentiate as autogenous graft will resorb or mature within 5 to 6 months. Allograft, which will be differentiated into an FDBA or a DFDBA, which will mature into 6 to 7 months or 4 to 5 months respectively. Xenograft is the longest graft resorbing graft. It may sometimes take 8 to 10 years, or in some literature it is seen it is never resorbed. Whereas synthetic graft, depending upon the size and the particle, the composition, it can be from 6 months to 2 years. Now, if you compare all the graphs according to their conductivity or their osteogenicity, we have the alloplast, which is, and the xenograft, which are only osteoconductive, whereas an allograft, if we have it DFDBA, then you can have a slight osteoinductive activity, whereas an autograft will always have osteoconductivity, osteoinductivity, and osteogenicity properties. Adjuncts to these bone grafts, apart from what you have, is basically a synthetically manufactured human sequence, naturally occurring proteins, which is called BMP, by recombinant technology, RHBMP2, which helps in having an osteoinduction property, and which is a synthetic way of converting a sort of an allograft into an osteogenic graft. Though these are present, but right now they are quite expensive and not regularly used into normal implant dentistry. Any graft is not successful without having a good barrier membrane. In this lecture, I won't be going into details about the barrier membrane, but I'll just differentiate or mention the different types, or how they're classified as rigid, which are fixed with screws or sutures, or which are non-rigid, which are secured underneath the flap. Very rare, but yes, this can be done. Resorbable, which are native collagen cross-linked or synthetic, and non-resorbable will be dense PTFE, titanium mesh, or expanded PTFE. The platelet-rich fibrin, which is by Chokran, which is very much into use or conducted nowadays. I personally don't use much of it, but still, platelet-rich fibrin, as described by Chokran et al., is a second-generation platelet concentrate, which contains platelets, growth factors in the form of fibrin, membranes, prepared from the patient's own blood, free of any antioxidant or artificial biochemical modification. So drawback in this is you have to be very well-versed with phlebotomy, and you have to have furthermore armamentarium. So like an autograft, when the patient is not allowing you to go to another site, it's not very easy to convince a patient to allow him to withdraw blood. Now as we know, we've seen the different type of grafts present, the characteristics, the properties, and their benefits. Let's see where we can use what. So these are the various grafting procedures we tend to conduct in our regular day-to-day life. Now, these would be something like socket preservation, or you can say socket augmentation, or you have immediate implant placements after extractions. You have onlay grafting procedures where you place block graft, or sort of something which you have to replace large chunks of graft material. You have interpositional bone grafting procedures, which will be a sandwich technique between two cortical plates, or a split technique where you split the cortical bone into two. Sinus lift procedures we do, which is direct sinus lift or an indirect sinus lift, or distraction osteogenesis. I don't remember of any other procedure where in implant dentistry we use. If I'm missing on anything, please excuse me. So first thing is, when you are having a implant where it is placed into a mature bone where there is hardly any bone loss or it is not an immediate extraction case, there you don't require graft material or very minimum of graft material is required. So we always pray that we get such type of condition, but unfortunately, when it is uh, time to place implant, patients generally come after a very long period where most of the bone structure is lost. So now person has undergone an extraction. So what has happened? On day zero, we have the clot formation. Day 2 to 3, we have small type of capillary growth or the angiogenesis which take place. Day 7, you have the granulation tissue which is formed inside the socket. Up by day 20, you have a osteoid tissue formation from the apex or from the walls of the bone, and on day 40, you have complete maturation of this osteoid tissue, and by day 60 you have a complete remodeling. Now when day 60 comes, the remodeling when it takes place, it might be along with the loss of the width or the height of the bone present available. So to avoid that, we have something called socket preservation or augmentation procedure. Whenever you have a socket preservation, it is always a 5-wall defect. Whenever you have the no more the number of walls, the better the chances of graft acceptance. Why? Because you have blood circulation from all the sides. In such a case, you will always get the best results. So if you have a 5-wall defect where after immediate extraction, the you place any graft, whether it's an allograft, whether it's a synthetic graft, or even an autograft, which is not recommended, we can have a good replacement or good maintenance of the height and width of this socket. I will always suggest to avoid xenograft. The reason behind it is xenograft does not resolve fast. Whenever it does not resolve fast, there is the particles which are present in that act as a foreign body and which will cause delayed healing and cause infection. So to in any case of socket preservation, avoid a xenograft, but always you can use a allograft, synthetic graft, or an autograft also. In cases where you have immediate implant placement after the extraction of the tooth, if the wall is present on all the sides, same protocol to be followed. If you have a missing wall on one side, maybe you can choose to place an allograft along with your autograft. If you have more than 2 walls which are absent, you can always place an autograft. A good principle would be let the implant surface be in touch with your autograft, and then on top of that you can use a xenograft or an allograft to maintain the width or the volume of that area. In cases of socket shield where you have to fill in with the jumping distance, allograft would be a good option, or a synthetic graft. A synthetic graft, something like a putty, no bone putty, which will always be easy to carry in that socket area. Whenever we have to go for a cortical onlay bone graft where you're placing a sort of autograft bone, in cases where you have more than 3 to 4 wall defects, it is where you have inadequate buccal or lingual width, or you can say where you have less of walls, maybe 1 or 2 walls. The best would be the autogenous bone graft, which is to be placed in such cases. This can be the gold standard of replacement where the donor sites can be taken from the symphysis, the ramus, or that's intraoral or extraoral. Even particulates graft from the nasal spine can be harvested, which will give enough of this autograft material in particulate. So if you have a block which is placed over there, then you can support it along with it with this particulate autograft. Once this block is placed, you can cover it with the allograft or a xenograft to maintain the volume such that the barrier membrane placed over these grafts do not fall off or do not get depressed, and the volume is maintained. Such areas which we have only one wall defect generally lose a lot of height and width. So we need to create a volume along with the the autograph. So to maintain that volume, a xenograph would be a better choice. In cases of interposition bone grafting, or where you have to place in between the two split parts of the cancellous bone, which can be a ridge split technique or a sandwich technique, you can have a combination of autogenous bone if available, or otherwise you can use a allograft or a synthetic bone. Why? Because in this it becomes like a 4-wall or a 5-wall defect. So whenever you have more the walls, it is the chances of having good bone maturation is high. So in such cases, other than the xenograft, you can use any type of graft which is good, readily available with you. Direct sinus lift always require volume to increase the height. So the graft material which is inserted between the the graft material which is inserted between the antral floor and the synovial membrane is basically placed so that we can increase the height of the antral floor. Why? Because of the pneumatic sinus, we cannot place a minimum ideal length of an implant. So in a direct sinus lift, you use a combination of a allograft and a xenograft. In such cases, you can add autogenous graft also, but since this is placed inside the sinus where you have ample amount of blood supply, you can have good results with allograft and xenograft. Now, if you have placed a direct along with the sinus lift, you have placed the implants, then it will always be better to cover the implant surface with autograft and then add to it allograft or xenograft along with it. In cases of indirect sinus lift, we have seen many cases where synthetic graft has been used to lift the sinus membrane. The most commonly one which is well explained by Dr. Udatta Kher, the MITSA or minimal invasive transseptal augmentation of the sinus. So you can use a synthetic bone putty in such a case, and if not, you can definitely add to it allograft or a xenograft. The particle size in here would be more of a large particle size. Why? Because you need the particles to have a volume and lead to separation of the synovial membrane to the floor of the antral wall. So if you have a smaller particle size, it would definitely not give that much of pressure to the synovial membranes. So choose a large particle size in this case. A very common scenario where post-implant where you have peri-implantitis. So in that case, you can have, if you have if you differentiate it into different types, like the horizontal defect, where you have one or two threads which are exposed. So you can basically do implantoplasty, where you can smoothen the implant surface and add to it autogenous or an allograft. You can always use a ring allograft, which will help to cover the complete surface of the implant from all the sides. In cases where you have a vertical defect, if it's a one wall defect, again, in one wall defect, as I mentioned earlier, that the more the walls, the better it is for regeneration. So if you have a one wall defect, chances are very bleak for coverage of such type of an implant. But still, after taking care of all the sterilization protocols of the implant surface and degranulation and using lasers and chemical decontamination or something like that, you can use, or you should be using more of an autograft at the surface of the implant, covered, supported above it by a xenograft to maintain the volume. Again, two-wall defect, you can have the same protocol, whereas in a three-wall defect, you can go for either a allograft or a xenograft. Wherever you have a circumferential defect, where the bony, where the defect is all around, but the uh, the RSQ of implant is good enough, where it is within the bony socket. You can use any of the grafts after decontaminating the area. But if it is outside the bony, if there is no walls present in any of the areas, then it's better to extract the implant. Before I end my lecture, these are a few cases which I would like to explain to you. As you've seen in this case, you have a missing first premolar long term, where the patient did not go for replacement soon. So if you consider this implant placement in the area, I will always say it is a three-walled defect. Why? Because we have the buccal and the mesial and the distal walls present and the lingual wall present. The only wall which is not present is your labial or the buccal defect is there. So we can place into such cases either a allograft or a xenograft, and along with that, a good barrier membrane to have all the graft into position, a tight closure, and the results you can see the replacement of the first premole in that area. Another case of extraction of a fractured tooth and the patient is left without immediate implant replacement. Patient comes back with after a few years where we placed the implant, and considering the height of CEJ of the adjacent teeth, a few threads are exposed. So in such cases, I can place an autogenous graft or a allograft and then cover it with a membrane. Results you can see after a few years, a good volume as well as good texture is maintained in such areas. Another case over here where the long-term patients have not replaced the missing molars in that area. You can see the width as well as the height is not as per to the acceptable size of the implant, minimum size of the implant to be in. We take a part of the chin graft, place it over there with the help of screws, support it with the xenograft, and place a membrane over there. And this is how we summarize, or I summarize my lecture, that autogenous graft is supposed to be the gold standard, where you cannot match it with any other graft. Limitations, as you know, I have already mentioned. So try to use more of autogenous graft. You have bone scrapers, you have ACMs, which help you into getting more and more of autogenous graft with minimum surgical interventions. More the number of wall defect, the better is the augmentations. Like if you have a 4 wall, 5 wall, 3-wall defect, you have better results in such cases. I will always like to let my autogenous bone graft touch the implant surface rather than any other graft until unless it is a 4 or 5-wall defect. If it is one of the one of the walls are completely missing in where it is exposed to the tissues, I will always try to have autogenous bone on the surface and then increase it with a xenograft. So it is not that if you if you want, you should be only using one type of. You can have a combination of autogenous, allogenous, or xenografts, or a synthetic graft. Whatever your graft you are using, barrier membrane is a must for isolation. If you don't have a barrier membrane, the chances of fibroblastic activity or fibroblast intervention into this graft area, which may lead to fibrous growth in this area, because fibroblasts grow faster than osteoblasts. So you should always have a barrier membrane which will avoid any type of fibroblastic activity in that area. Any type of infections should be avoided by tight closure of the wound, and immobilization of the graft is a must by fixation screws if you're using a block, or either with the particular graft, it should be tightly closed or fixed. The barrier membrane should be fixed so that there is no mobility, and infection control is mandatory. I hope I have covered up most of my part of bone grafts. I think Dr. Viraj, you can come up with the questions if at all you have. Or
yeah, Dr. Amit. Yeah, Dr. Amit. There is a question about autogenous tooth graft.
One minute.
Yeah, sure. Sure.
Yeah, tell me.
Yeah. Can you explain in detail about the autogenous tooth graft? Can you elaborate more on with cases and pictures?
Right now, I don't have it in this laptop. I have it in the other laptop. But if you want, I can forward you an article on this dentinal graft. Let me see if I have it right now.
Thanks, Dr. Amit, for a fantastic lecture.
Yeah, I have the article
friends.
with me. I have the article with me for this dentinal graft. Can you tell me how to forward it to you? Or maybe I can forward it to you.
WhatsApp, sir, WhatsApp.
WhatsApp में groups में डाल दो ना, if it is possible.
Okay.
Yeah.
Okay, I'll put it in the group.
Yeah. Okay. One more question is distraction osteogenesis. Can you please elaborate?
Okay, distraction osteogenesis, basically when you place a part of a when you have a controlled movement of a split part of a bone. It is basically autogenous type of grafting, where you separate into you fracture a part of the bone, and you have an osteogenous distraction kit where you attach it to two separate particles, and when you move it 1 millimeter per day, you tend to gain more of width or height required. Though it is not very regularly used, so that's the reason I have not mentioned much about it. I just mentioned the type of it. I can give a photograph also on the WhatsApp for this.
Viraj sir, do you have any more questions on your side? You are muted.
Yeah, sorry, I was muted. Yeah. What is the particle size? What is the particle size for autogenous graft during socket preservation?
It is basically the particle size for an autogenous graft is from where you keep collecting your graft. Generally, when you are using, whenever you are collecting it, you can either use a ACM or a bone scraper. In such cases, you have a very small particle size of 0.25 mm or 0.5 mm. You cannot have a large particle size graft because you need to have a very good circulation inside the socket. So in such cases, when you are doing it to close the jumping distance, if you are doing an immediate implant, then the size has to be smaller.
Okay. Dr. Sudhanshu is asking, is there a way to make a particle graft to make it in a putty-like that facilitates in easy placement?
You can use your PRF liquid or into and add into your powders, which gives a slide of a more thicker consistency and which is called a sticky bone, and use it as a putty. But the most important thing is the delivery system. The delivery system is very important in such cases where you have it either in a syringe or a compule, which can be injected in the area where you want to be. So in such cases, if you want to place it as a putty, it's good enough. If it is you want to push it inside a jumping distance, it would be difficult. So in that case, plain particulate will be better. In that case, you can definitely compress it inside the socket area or the jumping distance. Very important is you are not supposed to pack it very hard. You have to just place it inside and loosely pack it, because if you pack it hard, the amount of interparticulate distance will reduce, which will hamper the circulation around the graft materials.
Dr. Jashan, anything from your side?
Yes, so there is a question. He's asking cases where sticky bone can be used.
I didn't get to. Can you repeat it?
The cases in which you can use sticky bone.
You can use sticky bone wherever you want to use it. Basically, sticky bone has got no different requirement or no different functionality. It is basically the way to carry your graft material to the host site. So it is not that sticky bone has a different function. It is only the way how to handle your graft material.
Great. There is one question. The role of BMPS.
BMPs is basically it's a bone morphologic growth factor, and it enhances the growth of osteoblastic activity. Now, as I've mentioned earlier, that these BMPs which are present, which are right now available, but a little on the expensive side. So since I haven't used, I cannot give you much details about it. But yes, they enhance osteoinduction. So it is a good reason or a good thing to use in bone grafting procedure.
One last question. So you have a question, Viraj sir?
So what's the difference between FDBA and DFBDA?
What?
What's the difference in demineralize and mineralize this thing? You told about allograft, right?
Yeah.
So DBA and what is the difference in that?
One is demineralized and one is mineralized. The demineralized is basically exposure of the protein factor into the mineralized bone graft.
Okay.
That's a basic difference.
That is the difference. Okay, thank you. And sir, can you explain about the different particle size in different grafts? Like for direct sinus lift, we should use the larger particle size, right?
See, where it all depends what case are you doing. Now, if in case you have a huge defect, now sinus lift is always considered a very huge defect. So there you require a lot of volume. When you use a smaller particle size, you require a lot of graft material. So in such cases, you should use a large particle size where you have to do it in immediate extraction implant placement, where you have a very thin or maybe 2 or 3 millimeter of jumping distance. Use a smaller particle size so that it is easily packed inside to the up to the end. Rather than just if you in such cases if you use a large particle, you will be able to pack only on the the coronal part of the implant, and nothing will go inside. So inside it will remain as a jumping distance. So that's how you can always mix and match depending upon the case.
Okay, and sir, to cover the jumping distance, why allograft is more preferable than xenograft?
I did not say that xenograft is not preferable. Basically, what happens is in a jumping distance, it is basically a four-wall defect. You have blood circulation and osteoblastic activities on from all the sides. In a jumping distance where you have a xenograft, remember, it does not resolve for almost 8, 10 years, 15 years. Yes. You do not want some graft material still lying attached to the implant surface. Whereas an allograft will, or a synthetic bone, you can say, will always mature within 6 to 8 months or maybe 2 years. So after 1 or 2 years, you don't want anything which is artificial. So that's the reason a xenograft is not preferred as compared to allograft or a synthetic graft.
Okay, thank you. Okay. Thank you so much, sir.
Friends, Dr. Amit Gupta will be there to answer your queries on the webinar WhatsApp groups. But there's an important message from me right now. Indian Dental Association head office has gone on Facebook Live concerning giving details and the methods and what we need to do in this time, and when we will be able to open our clinics, private practice, and everything, what precautions have to be taken. The link to the same will be sent on the all webinar groups right now immediately. Dr. Amit, I think so that's fine, I suppose.
Yeah.
Huh? So Dr. Jashan,
I'll be there for the questions on the WhatsApp, and at the same time I will forward that article. So if you want to,
yes, sir.
Who want to see that article on dentinal grafts, they can go through it.
Yeah, Dr. Jashan, so I suppose today's meeting, I know we are 15 minutes ahead of time, but since there's an important announcements and lectures going on, important matter going on FB Live by Indian Dental Association head office, request everybody to join the link. The link will be sent on the webinars group right now.
Yes, please.
Jashan, you can end the meeting. Thanks, Dr. Amit. Thanks a lot.
Thank
you tomorrow.
Much.
Meet you tomorrow for Dr. Parag Kelkar's lecture.
Yep, ending the meeting right now. Thank you.